Let's learn now about antimicrobial. Despite over 70 years of clinical antibiotic use, bacteria continues to outperform the clinicians by developing resistance to both old and new antibiotics. And just as bacteria continue to adapt, clinicians must continue to adapt their practice. It is a policy report. It has been stated that multiple legislative, regulatory, and funding solutions were suggested. IDC and Bad Bugs Notice policy report mentioned that lack of drug research and development is a political action committee is an imperative. Studies have demonstrated that inappropriate initial therapy is an important independent determinant of mortality. The CDC estimates 1.7 million patients contact healthcare patients every year, and nearly 99,000 of them die. What are the pathways to a successful stewardship program? Stewardships are processes designed to optimize the appropriate use of antimicrobials by ensuring that every patient receives an antibiotic only when it is needed, with right agent, right dose, right route for the right duration, in order to optimize clinical outcomes and minimize unintended consequences of antimicrobial use. 200 to 300 million antibiotic courses are prescribed annually. 45% are outpatient use. 25 to 40% of the patients receive antibiotics. At least 30% are unnecessarily. 5% experience adverse drug reactions. The wrong reasons are because of to save money, because we ain't control the physician's prescriptions, and there's a lot of order for antibiotics. There should be a lot of antibiotic overuse. Now, stewardship is required to improve the quality of care, to create a multidisciplinary program, and to improve the antibiotic. Develop a culture change which embraces prudent antibiotic usage, identify and gain solid commitment, items to support the essential. From the microbiology laboratory, the successful interventions include rapid testing and notifications, procalcitonin results, blood cultures results, antibiotic development and education, improved antibiotic guidelines. While for nursing, it is IV to oral switch on time, anti-identification through allergy, rapid initiation of empirical antibiotics. While from the infection prevention is to see that HIS, that is hospital-acquired infections, are treated optimally, maintenance of sterile injectables, and others. While medical staff, their responsibility includes antibiotic plans in charts, computerized precision order entry educational screens, and restricted or non-formal antibiotics in place. Who can direct this program? Small institutions may not have the ideal physicians and may not have the time to contribute to program, but the basic requirements of a potential champion is imperative. Who has interest in stewardship, patient safety, and performance improvement. Basic knowledge of antibiotics, dedicated time, and activities are scalable. So, judicious use of antimicrobials in order to improve patient outcomes, control resistance, and decrease healthcare expense is the part of this core strategies, which includes it achieves through education, guidelines, order sets, dose optimization, IV to oral switch, streamlining, and information technology. Flow diagrams here will assist in the labor and time motion studies, but may be too complex or intensive for current healthcare systems. Comprehensive program led by ID physicians, pharmacists, and microbiologists is required. Individual interventions based on goals of institutions with assistance from interested individuals is imperative. Simple initial strategies include simple audit, pharmacy, order data entry system, develop evidence-based guidelines, educate the medical staff. All pharmacy can apply guidelines, post-prescription review, IV to oral switch. The antibiotic support team should consist of the ID physicians, pharmacists, members of infection control, and microbiology. Take inventory of your own resources, meet with anybody who will talk to you, gather the baseline data, write a proposal, get approval or acknowledgement of your plan, and pilot your interventions. While taking inventory, note that is it only me or identify MD and champions, stakeholders. Meet with anybody that who can talk to you because they don't understand the docs will never go for this. So have a moral support, understand what are the problems, have to define the goals and objectives, review the goals and objectives, and go slow and focus on low hanging fruit and identify the best performance. How stewardships make it is have formulary management versus patient centered program can both be accomplished simultaneously. Pre-prescription review may restrict the expensive agents to enforcement of empirical guidelines based on the anti-background. Post-prescription review may focus on expensive agents or commonly used antibiotics. Disease-specific objectives can be challenging but are aligned more closely with clinical outcomes. Focus on formulary management as the sole objective limits the stewardship program to control the drug cost and clinical outcomes. Accountability of the stewardship team elements for a business model consists of decreasing the antibiotic budget by 20% each year for 2 years, increase the physician and pharmacist knowledge, and have specific end goals such as decrease the duration, increase the IV to oral switch, create guidelines, decrease the readmission rates, decrease the number of patients receiving 3 times the antibiotics by 50%, eliminate the duplicate therapy, increase the antibiotic therapy, increase the de-escalation, decrease the vancomycin use, and eliminate the vancomycin therapy for blood culture contamination. Don't promise what you can't deliver. Decrease the bacterial resistance, decrease the Clostridium difficile infections, and cost savings which are unlikely. The cost of HIS is significant, but lower HI rates is not a promise to be made. The CDC estimates that 1.7 million contracted healthcare associated infections, as said before, and nearly 99,000 of them die. So HIS are the major concerns for patient safety. While every effort should be made to decrease the HIS, stewardship programs may directly impact the rates of Clostridium difficile infections and surgical. IV to oral switch, pharmacodynamic dose optimizations, discontinuation of the duplicate therapy, pathogen-directed therapy, then access potential to change the antibiotic prescription habits are some of the interventions. Now, several resources will be a part of this business plan, like such as antibiotic approvals, post-prescribing review, surveillance of the antibiotic utilization and resistance. The internal preparation consists of identify the list, understand the cost, organize into present cost, cost of inaction, and cost of different actions. Structure a best alternative to negotiate an agreement, and then the external preparation includes evaluate the past obstructions, what are the hospitals BATNA, and establish fair market value. Effective antimicrobial stewardship programs can be financially supported and improve patient care. Comprehensive programs have consistently demonstrated a decrease in antimicrobial utilization by 20 to 36%, with annual savings of $2 lakh to $9 lakh in both the large academic hospitals and small community hospitals. A structured antimicrobial stewardship program to strengthen the compliance with treatment guidelines may impact the patient outcomes and the length of stay. A multidisciplinary committee sought to optimize the initial selection of antibiotics is imperative. The combination of interdisciplinary teamwork, antibiotic stewardship, education, and information technology is associated with replicable and sustained prescription improvement. It was observed that the antimicrobial stewardship activities have occasionally reported a decrease in the bacterialization, but this is difficult to achieve and is likely multifactorial. However, the effect of antimicrobial stewardship on Clostridium difficile infection is well documented but relies on many. The basic approach, if done right, an intervention will save money, improve outcomes, and increase provider satisfaction. Identify the activities in your facility, meet with the stakeholders, and see if there are opportunities for reduction in the length of the stay. Now, what is the peak for stewardship programs? Hospital administrations use the evidence from other institutions, be synchronous with the goals of the hospital administration, see that to decrease and control costs, improve regulatory compliance, remain competitive with the surrounding institutions, optimize the patient safety. Winning over hospital administration means winning over pharmacy directors too, but there are additional activities which are pharmacy department specific. Review the antibiotic formulary and what is on the shelves, work with the purchasing agent, batching of IV antimicrobials, analyze the pharmacy workflow, study the root causes, assess the availability of antimicrobials, and improve the regulatory compliance. The pitch for stewardship programs consist optimize the patient safety, regulatory compliance, potential to reduce resistance, what efforts and interaction do they need. Stewardship will help them make better care for patients, guide therapy, de-escalation, guide dosing, IV to oral switch, decrease the unintended consequences, prevent adverse effects, guide drug compliance, and improve the drug compliance and the drug selection. Thank you.